Interstitial nephritis is not. Because it's a chronic fibrosis and inflammation, you can't cure it. It's going to progress no matter what. So does it make any difference if you make the diagnosis early? No. There's nothing you can do other than start them on sub-Q fluids at home and maybe diet, which I'll be talking at length about. But progression can result in hypertension, soft tissue mineralization, and proteinuria, those latter two being more common in dogs. Let's see here now. We can, with just using creatinine, so not spending more money on SDMA on another test and sucking more blood out of a cat, we can make an earlier diagnosis of chronic kidney disease if we use longitudinal assessment. If we use longitudinal assessment. So longitudinal assessment, if we're, for instance, seeing a cat who has gone from having an 80, well within normal, creatinine, 80 micromoles per liter, to 160 micromoles per liter, that tells me that their GFR is half. The 160 is still within normal, right? Up to 180 or 190, depending on what your lab says. As the reference interval, that's the low normal. So if it's gone from 80 to 160, even though it's still within the normal reference interval, you know there's been a decline in kidney function, right? Okay? The other thing you can do is say, well, if the problem seems to be where the bottom of our reference interval is, let's move the reference interval down. And in fact, if you take a creatinine concentration if you decide that you're going to take your creatinine concentration and move your upper reference interval, forget these numbers, I was just looking for a Gaussian curve. If this is your upper limit of your upper reference interval, and you move it down to 141 micromoles per liter, then that's exactly where SDMA starts to rise. Okay, so you don't need an SDMA. You already have your answer with your creatinine. If it's a single value, you just drop your upper limit, or pardon me, your lower limit of your upper limit of your SDMA. No, your lower limit of your SDMA. Okay, you just shove this over here. And if you or if you've got multiple readings, you want to see whether in the same degree of hydration, what's happened with that creatinine. If it's gone up, even if it's within the normal reference interval, then you've got a decline in kidney function. So we really don't know, and this is from the IRS stage. They say this with respect to SDMA to upgrade stage, to pick things up earlier. Possibly, but in reality, based on early data using SDMA, we expect them to be updated as the veterinary profession gains further experience using SDMA alongside creatinine, the long-established marker, and what we rely on. So that's something that one can think about. The thing, too, is SDMA isn't only affected by GFR, so pre-renal azotemia and renal blood flow. Here we've got a situation where SDMA patients with weight loss have significantly lower SDMAs. Okay, that's going to confuse things because a lot of times cats with kidney disease have some weight loss. They also found that hyperthyroid cats, again, we can't differentiate between the hyperthyroid cats who we don't know whether they have kidney disease or not, because the increased blood flow from the hyperthyroidism due to the increased cardiac output. That we can't tell whether that is due to whether there's underlying kidney disease or not. SDMA can't find that for us. There's a relatively low sensitivity, meaning it fails to predict azotemia in most hyperthyroid cats. And again, we've got just GFR and blood flow. Here also with looking at cats who received radioiodine, there were discordant outcomes between SDMA and creatinine after radioiodine, suggesting that there are extrarenal factors that may interfere with the reliability of SDMA. So, with SDMA, does it solve all of our problems? No, there are non-renal influences that negatively affect specificity. There's biological and individual day-to-day variation within SDMA. Age may influence it, kittens versus adults. In Berman's SDMA may be more accurate. Large tumor burden, especially lymphoma, can result in increased SDMA. It's lower in cats with diabetes. I've already mentioned lower in cats who've lost weight. Some concurrent diseases may influence SDMA. So we really don't know. In other words, SDMA is a fail-proof biomarker for chronic kidney disease in cats. True or false? False, exactly. Okay, so it's another tool in the toolbox. But while with something like FIP, you need many, many tools. With kidney disease, I don't know that it really adds anything. Now, cystatin B, I mentioned cystatin C. Cystatin B might be helpful in the future. That's another one that's being worked on. Okay, so this is Foxy Cleopatra, and Foxy has a history of, she's dehydrated, she's on tapazole, methimazole for her hyperthyroidism. She's also on amlodipine because she has she's hypertensive, and she has a frequent hairball every couple of days. So we have that we're doing our bloods. Her creatinine is 193 with the reference interval being 89 to 189. So it's 89. Her spec gravity is 1.020. Okay, so 1.020 in a dehydrated state, that supports that there's kidney disease. And her urine protein is 0.3. What stage is her renal disease? If you look at these values here, creatinine, she's got a 193 micromole per liter creatinine. What stage is she? What stage is she? We don't know. We don't know because she's dehydrated. See, now you'll remember that because you felt a little foolish there, didn't you? Yeah. You can't stage them until you rehydrate them. They have to be rehydrated. Okay, so treatments. Can we use antibiotics only if it's very specific? Calcitriol, no. Chemotherapy, well, you're not going to save them anyways. Antihypertensive, antiproteinuria, if they have those issues. Late stage 3 and 4, we're focusing on disease-associated. But always, in the last presentation today, I'll be talking about this frequently, namely hydration, nutrition, analgesia. Hydration, nutrition, analgesia, and reducing stress. We want to go back to these things, the slow progression and improved well-being and longevity. So azotemia, metabolic acidosis, anemia, hypophosphatemia, proteinuria, and hypertension. Definitely want to be looking at those. Predictive of a decline are weight loss and poor body condition. Nutrition. It's super, super important. Now, in blue here, I've highlighted those things which are affected by hydration, improved by rehydration. And when I talk about rehydration, I mean not just rehydrating, I'm very, very dehydrated. Okay, I'm going to rehydrate you. My level of water has gone up. I'm rehydrating you. And then I get dehydrated again, and then I rehydrate you. That's not what we want. That's not what we want. We want to rehydrate somebody and keep them hydrated. Then they're going to be well. That does not come from fluids twice a week, or once a week, or once a month. That comes from daily fluids. And it's actually easier for people to get fluids daily, just like it's easier for you to brush your teeth twice a day than to think about it. Let's see, did I brush my teeth? I brushed them last Monday, I'm fine. Okay? It's much easier for a habit if you do it every day. So, okay, the second part of staging is not based on creatinine, but rather based on proteinuria and the presence and degree of proteinuria and the level of blood pressure. So I'm going to talk here about proteinuria. Proteinuria, really simple calculation. It's urine protein divided by urine creatinine. You need the lab to measure the urine creatinine. Non-proteinuric, as I said, is less than, they have a good life expectancy if it's less than 0.2. If it's greater than 0.4, they have a crappy life expectancy. Okay? But dogs, instead of cutoff, would be 0.5, just to point that out to you. Proteinuria, you have to decide though, is it real? Is it real? Is it persistent? Where is it from and what kind of protein is it? Because proteinuria treating protein for proteinuria is not required in all patients with proteinuria. You have to know what's causing it. For instance, I can cause proteinuria if I ran a marathon, which at my age I wouldn't be doing anymore just because of a whole bunch of stuff. But if I was running a marathon, it's like Monday morning sickness in horses. I would be, my urine protein would be increased because I would have broken down a whole lot of muscle in the process. So that's something. Cats generally don't exercise a whole lot, but multiple myeloma. There's other things that can cause, then where is it from? Is it pre-renal? Pre-renal, so functional, okay, like myeloma or running a marathon. Is it renal? And if it's renal, where is it from? Is it from the glomeruli? Is it from the tubules? Is it from the interstitium? Okay, that's because the drugs we use don't treat interstitial proteinuria. They treat glomerular proteinuria, and I've already said cats don't do that a whole lot less than dogs do. Or is it post-renal? You might get post-renal proteinuria because you've got infection or inflammation. Idiopathic cystitis, you're going to have increased proteins in your urine, and that's going to be from, and you'll see also red cells in there. So when you measure a proteinuria, it's got to be in a urine with a quiet sediment. In other words, no red blood cells, no white blood cells, no bacteria. Okay, a really boring, bland sediment. So, glomerular is what we're really looking at there. Let's see. When should I do a UPC? Persistent proteinuria, again, so more than once, with normal quiet sediment or maybe some hyaline cast suggests glomerular disease, and that's what we want to treat then. Let's see. And how are we going to treat it? Well, you could use an ACE inhibitor, something like benazepril. It works by essentially redirecting the blood flow so that instead it comes in the afferent arteriole, and because there's increased blood pressure in the glomerulus, it's forcing that protein out of the blood into the urine. So that's where you're measuring it. But what we want by dilating the efferent arterioles, by selectively dilating that efferent arteriole, we can then sort of reroute. It's detouring that blood and reducing the blood pressure, and therefore we don't lose the protein in the urine. So that's one way we can treat. So benazepril, and that's we want to always monitor the creatinine and monitor the blood pressure and monitor the UPC. It may reduce glomerular filtration rate, which we don't want because that's not a good thing, and monitor the quality of life. Now, angiotensin receptor blocker, angiotensin 2 receptor blocker, telmisartan is now the best ideal way, and you apparently only have it here for humans in 40 milligram tablets, which is way, way, way too high, the dose, so you would need to reformulate it into lower doses for cats. Boehringer Ingelheim and other parts of the world makes it as a cat dosing called Symmetra. So it works in a different way than the ACE inhibitors, and it is extremely, extremely helpful, much better than ACE inhibitors. You can see the doses up here, and if you need to, you could use it alongside an ACE inhibitor. But again, you need to monitor these cats. So you want to check after 3 to 5 days, are you seeing a decrease and improvement in the urine protein creatinine ratio? Because if you aren't, stop using it. There's no point in using drugs. It's like if you're using an appetite stimulant and they're not eating more, stop using it. You know, it's just more stuff for your body to have to deal with. Hypertension. So hypertension is really, really problematic in cats. Cats with a progressive chronic kidney disease had blood pressures that were higher than cats with stable chronic kidney disease. We know that it causes progression in these 69 cats with naturally occurring chronic kidney disease. The systolic blood pressure was significantly higher, 159 versus 136, and it was correlated with glomerular sclerosis and hyperplastic arteriosclerosis. I already said 65% of cats with chronic kidney disease have hypertension, and some studies even suggest that it might be higher than that. And we want to treat when the systolic pressure is consistently greater than 160. I do a whole lecture on blood pressure, and that would be really useful right now, but to try and encourage you to measure blood pressure, but I so don't have time, it's not even funny right now. If we might treat earlier if there are hypertensive complications, such as retinal detachment, as in this cat. Also, the hypertension affects not just the eyes, it affects the brain and the kidneys, it affects also the heart and the brain. There's risks of sustained hypertension, the target organ damage we talk about, those 4 target organs, brains, eyes, heart, and kidneys. There's a great risk for future target organ damage when the blood pressure is greater than or equal to 160. They're severely hypertensive, high risk. 160 to 170, they're hypertensive. 140 to 159, they're pre-hypertensive, and less than 140 is what we want to see. Now, this is, a lot of times a common question is, well, how do we keep their blood pressure? How do we know that it's going to be elevated just from them being in the clinic, from being frightened? How do we deal with that? To which I say, first off, you use cat-friendly techniques to help reduce the stress in that cat-friendly environment, cat-friendly handling, and you also are, if you measure blood pressure with positive reinforcement in cats from every time you see them, then you're going to be better at doing it, and you're going to be less stressed, which means that the cat's going to be less stressed, plus they'll be used to it. Regardless, even by saying 160, we'll start treating 160 and above, is already giving them wiggle room, because just like us, normal blood pressure in a cat is 120 over 80. So by saying that normal tension is less than or equal to 140, we've already given them wiggle room. And you just keep measuring it until they're relaxed, and it's really a nice thing to do. Front limb, back limb, or tail. There's a very excellent hypertension education toolkit on catvets.com. Teaches you how to do it, and there's the ISFM consensus guidelines on the diagnosis and management of hypertension in cats. We also know that blood pressure in healthy cats, this was a study looking at 780 apparently healthy cats, and with these 780 cats, they looked at the role of stress, so what we used to call white coat syndrome, what we now call situational hypertension, and they took up 780 cats. They were in shelters, rehoming centers, and using the Doppler to measure, which is the best technique, using a Doppler, they found that in these 780 cats, it's 120.6 in shelters. That's what happens if you get good at doing these, you actually get good values. Okay, so they, because surely a bunch of them were stressed out of their treatment. You can see it only went up to 132. All right, so treatment, we're going to use amlodipine or telmisartan, because telmisartan, which we use for proteinuria, is also effective for hypertension, but at a different dose. So amlodipine, which I expect is what you're using now, or we use telmisartan at a different dose. We can combine the two if either drug alone does not lead to adequate control, but we have to make sure that these cats are not clinically dehydrated, because that will really, really mess them up, or showing signs of hypovolemia. So correct dehydration before using these drugs, otherwise glomerular filtration rate can drop precipitously. Oh goodness, 2 minutes left and so many slides. So what about etiology-specific therapy? What about bacteriuria? Has it ever happened to you, this certainly happens to me, where we do a urinalysis in clinic, we read the sediment, we see bacteria, we send the urine out to culture, and we get back no growth? Has that ever happened? No growth? Frustrating, huh? Expensive and frustrating. Well, it could be that the body's done exactly what it's meant to, and the bacteria you're seeing are actually non-viable at the time. Or perhaps you already have them on antibiotics. So that's a possibility. It could be that the urine sample was improperly handled and the bacteria died before they made it to the lab. It could be that they were really, really delicate organisms. It could be that you've requested the wrong type of culture. Maybe they're anaerobes or L-forms rather than aerobes. And it could also be that we've just misidentified them as bacteria when in fact they weren't. Uroliths, ureterolyths, they have been diagnosed more commonly. Mostly they're calcium oxalates. That's why we take these x-rays once a year, plain films, so that we can, if we see them, we're going to, even if they're only in a stage 1 or stage 2, I'm going to start them on daily subcutaneous fluids, because just like bladder crystals, I want to make sure that they don't grow, right? I want to make sure that they don't grow and that they're peeing frequently. Take radiographs. So non-specific, hydration is the most important thing. I'll talk nutrition momentarily. Proteinuria hypertension I've already talked about. So let's go to fluids. Already talked about hydration. We can increase water intake. Really, really important. With lots of, we want to make sure that they have, for instance, more stations of water at home, that the water's really, really fresh. We want to have maybe a water fountain, maybe they like it, but they don't all. We want to give them flavored water, so chicken broth, tuna water, clam juice, things like that, so that they drink more. We don't just drink water. We get pretty bored with that over time. Canned food, adding water to the canned food, adding water to dry food just before you feed it to them, not letting it go mushy, but rather just floating the dry food on the water, and then they'll take in more water, and then also feeding small amounts more frequently, like I talked about yesterday, because cats will actually drink more water then, and daily sub-Q fluids. So let's just look here at rehydration. Let's look at rehydration. Let's say you have somebody who, when they were healthy and hydrated, they weighed 4.8 kilos. You okay with me using kilos? Okay, 4.8 kilos. And today they're ill, they're dehydrated, and they weigh 3.7 kilos. So remember, we have to recoup the deficit, and then we have to give them maintenance and potentially ongoing losses. But in the case of kidney disease, it's chronic kidney disease, not acute. It's usually just deficit to rehydrate and then maintenance. So I'm going to estimate the deficit based on the findings of, first and foremost, not as of delay in skin elasticity, because I tell you, when you become my age, I have a permanent delay in skin elasticity. That's called lack of collagen, lack of elastin, just from age. And these are older cats, so it's very hard to estimate that. Also in kittens, it's really hard because they have a bounce to their skin even when they're dry as a bone. So I'm going to use fecal consistency, because the only thing that makes hard feces is dehydration. That's it. There's nothing else that makes hard feces. So palpate the abdomen. If you can put a dent into it versus if it's rock hard versus if you can really break it into bits. So feel for that. Delayed skin must be slightly dry. Let's say this cat's also got some firm feces. She's got rather slightly drier oral mucous membrane, so really dehydrated, but normal eye position still. So I'm guesstimating 8%. So what I'm going to do is I'm going to know that I've got a cat who's got 8% dehydration. So 8% dehydration, that means for my deep rehydration, maintenance plus dehydration factor, my dehydration is going to be 140. So remember I said I'm using her hydrated weight, not the 3.7, I'm using the 4.8. I'm using the 4.8. Why? Because her deficit is relative to her hydrated weight. It's not relative to her dehydrated weight. Does that make sense? Okay, really important. It's like when you're figuring out calories in somebody who's underweight or who's overweight. You have to use their ideal weight to figure out how many calories they need, not their current weight. Otherwise, the fat will get fatter and the thin will get thinner. So I'm going to use this 140 times 4.8, which is 672. I can give those 672 intravenously at 28 mils per hour over 24 hours. And then once they're rehydrated, I reduce the amount. Or I can go sub-Q, in which case I can take those 672 mils and divide it into 3 boluses. Okay? I'm not just going to give 200 mils once. That wouldn't be rehydrating her. In fact, that's not even meeting her maintenance requirements. She needs 672 mils. Doesn't matter which route. Okay, so 672 mils. Once she's been rehydrated, then I go to my 60 mils per kilo, because cats need 60 mils per kilo per day. Yes, some of it comes from food, but unless you've watered that food down, not a lot. So 60 mils times 4.8 kilos per day, that's 288 mils per day. And you may think that that's an awful lot to give to a cat who's less than 5 kilos. It's not. Well, my cats won't sit still for it. Why? Because as I said yesterday, this room is 20 degrees. That cat is 38 degrees. Not fun. So we want to warm the fluids, and we want to redirect the needle, not jab them twice, but just redirect the needle under the skin so that it goes into 2 places, and we want to, like over the shoulders, and we want to reward them throughout the whole, give them treats throughout it. I've already said yesterday, more small meals results in more drinking, so puzzle feeders. I already yesterday talked about the fact that dehydration plus acidosis makes a hangover. That's a hangover. You're irritable. You have a headache. You're inappetent. You know, you may even vomit, or at least be nauseous. You're lethargic. You're constipated. Okay? Now, and that's what happens with us, and that's what happens with cats. So they have a hangover, not just for one day, not just for 1 week, but for the entire month, for the entire year. That sucks. They need to be hydrated. Metabolic acidosis, not going to go through all of this slide in interest of time, but it's a bad thing. Hydration corrects that. So really simple. Okay, so I said 60 mils per kilogram, ideal weight per day. They don't like cold, they like warm. So we're going to teach people how to give sub-Q fluid, how to warm their fluids. First thing is how to warm their fluids. And this is in the lecture handout, the lecture notes, so it's already there. If you haven't attached the line, you microwave the bag. If you have attached the line, don't microwave the bag because you'll have to get another line. So you're going to I put it upside down in a vase and pour boiling water on it, whatever. Then how to connect the new line to the bag, I teach clients. Then how to give your kitty fluids. And I've got a video which I'm happy to send to anybody who wants it. But what I'm going to do here is just show you. This is going to be my IV line. This is going to be my cat. Oh, very interesting, talking on the side of it. This is going to be my cat, head, ears, okay? Nose that way, tail here. Yeah, right? The way I teach clients how to give fluids is to rest the hand with the needle on the back of the cat. Then they never jab the needle. They never jab the needle. They pick the skin up and they pull the skin over the needle. Oh. So you learned something today.